Thank you, Lalu, and thank you, everybody. I'm extremely delighted to be at CMC Vellore. This is technically my first, like proper official visit, although I've been around once in a while. Really thankful to everyone. So initially, you would notice that I had the standards written my topic, and I saw Manisha speaking before me, and we changed. Okay. Oh, all right. Okay. You could get the collar mic? No. Collar mic? Okay. Is there a collar? Okay. I'm so short that I don't stand behind the podium, right? Discovered it quite early on in life. So we will discuss, it's just carry forward from what the previous speakers have been saying. So let's look at how we worked at the telemedicine registry. So when you look at telehealth solutions, it's not telemedicine consultation alone. It's tele-ICU, tele-ophthalmology, telepathology, you have tele-everything. But in addition, you also have a lot of devices that gather data remotely, or you help remote monitoring of patients. I noticed that tomorrow there is a talk by Janitri who does remote monitoring of ultrasound, fetal ultrasound. All that is also part of telehealth solutions. So telehealth is a huge subject. And if you looked at the digital health ecosystem as a pyramid, I would look at telehealth at the base of this pyramid. This is where the basic initial data collection will happen. It's happening wherever. But eventually, when you have a fully mature ecosystem of digital health, your first data collecting tool will be a tele tool. And that's where it's very, very important to realize that we need to have an extremely robust base and a very robust telehealth system before we can talk of reaching the apex of the pyramid. And when you want to do telemedicine, and this is a question that Kaho had asked us and what Lalu alluded to, when COVID happened, I'm sure all of us noticed, and every practitioner was inundated by a lot of telemedicine solutions being provided. You had a lot of fly-by-night operators coming in saying, I have the best telemedicine solution. What would a doctor choose? What would a hospital choose? This was a big question. And there were people who had experience, they bought something because the technology provider showed them something, but it didn't work in the field. So we realized that users need to know how to evaluate this technology solution. And we as doctors, we are quite technology blind. We don't understand what the technologists are talking to us most of the time. So, unlike many doctors in CMC, when you see the outside CMC world, the doctors are quite technology blind, and we don't understand. Also, the hospital administrators, you have CEOs who probably don't have an understanding of healthcare and technology. So, that's how the world is. So in this scenario, we needed to provide something, and the solution is to be chosen based on your need. And there was no tool, we researched the literature, we found there was no tool that could really provide this to a doctor. So we understood that we need to figure out some mechanism where there is a comfort to the user that, okay, what he's choosing, like out of the 200 solutions available, he can choose what is required for him, and he doesn't need to copy some other hospital or some other provider. And there had to be some reference point as a base. Telemedicine practice guidelines had just been released, and we used that as the base reference point, saying that that must be the base that every solution must provide. Because we had found that many solutions, excellent features, not conforming to the telemedicine guidelines. So we developed from there on to just help the people make a decision. Okay, so what decision do we have to make? So it depends on what is the size of the healthcare provider. Now you have CMC Vellore here, and you have 50 other mission hospitals that are affiliated to you. Ideally, you would like to have a solution which actually works in all these 51 hospitals, right? Which can integrate the workflow in all these You not only have that, you also have patients who come from far and wide, all across the country, and you would have a solution. So obviously, your system needs to be that robust. We also needed to see what is the digital health maturity system of the institution. So CMC has a fairly mature infrastructure and institution. A lot of big private hospitals like Max and Fortis, they have a fairly mature digital health ecosystem within them. So their needs are different from, let's say, a single clinic or a newly formed 100-bedded or a 500-bed hospital. So that had to be kept in mind. And we also had to see what is the maturity level that has been attained by a telemedicine solution. And that's a maturity model that did not exist in the market. And we decided along with our partners that we will develop, we'll work on this. So across the healthcare system, the needs were different, and we decided that we need to define their needs. So on the one hand, we mapped the maturity model of the system, and we mapped it against what is the evolution of the clinical usage of that solution based on the complexity and size of the healthcare provider. And the framework had multiple levels, which had statutory levels. The solution had to actually demonstrate to us. So what we had done was that we basically took initial data from them, screened them, and after that, we asked them to do a practical demonstration to us of the entire solution. And we looked for features that they had, features to identify all the stakeholders in the consultation, the doctors, the patient, if there were patient's relatives, how to validate their identity, if there were multiple doctors validating their identity, authentication of these identifications, and consent management. And consent management has different levels, and I'll come to that in a while. And whether it had the basic records which was saved for, and it could be controlled by the patient, possibility of information exchange between solutions, the basic workflow of clinical medicine, whether it was a seamless workflow, and if there were special features that were contextual, that were also there. And according to this, we categorized into a beginner type solution, the intermediate, and an advanced level solution. So in the beginner solution, consent is very basic. It's an implied consent that a patient calls you. It's an implied consent. So telemedicine practice guidelines actually, talks about implied consent. So we said, okay, that. So it had just implied consents, very basic asynchronous calling. The doctor calls, leaves a message, or the patient calls, and the doctor gets back. That's a very basic thing. At the next level, at the intermediate, it has to be a fully compliant solution as per the present TPG guidelines, which means that there has to be an identification, authorization, consent management, e-prescription, and a basic patient record. And here the consent is explicit. Now coming here, I want to talk a little bit about consent. This is related to the entire digital health ecosystem. We all are used to taking patients' consent when they come to the hospital about services being provided in the hospital. And then we go further into procedure-specific consents when we need to do a particular procedure. Now, this digital tool is a new tool for us. We need to now start taking additional consents for use of data, because data management has certain components that we need to separately consent for. It is not a legal, statutory requirement as yet, but if we understand how we need to work with data, we realize that we need to take that consent to protect ourselves and also to protect our patient. What would be the consent? We are using a third-party solution for, I'm not talking of CMC because you have an in-house solution, but most people have let's say, a third-party solution. We have no idea who's built that solution. Okay, now they are our partners. We need to take patients' consent that they're okay to use that third-party solution for data capturing and data storage. Because anything that happens to breach of data security in that solution can actually harm us and also the patient. So there has to be an understanding between the hospital and the third-party solution that they are equally liable as the hospital is, But in addition, we need to have the patient's consent that we are okay. So we have decided, I'm sure patient who's coming to us will not say no, but that consent we must take. Additionally, data sharing. Data sharing is for two different broad purposes. One is for care being provided in the hospital. So that data sharing, which is required for their immediate care, so that is one. Second is for research and for, let's say, doing AI on an unidentified data. So even for research that we do on de-identified data, we should take consent, because what is de-identifiable today, tomorrow can be easily identified. So it's necessary that we protect that patient, and therefore put these three. But however, at this moment, TPG guidelines are okay with even an implied consent. That's the basic. So we worked at explicit consent as in the intermediate solution. And of course, multimode synchronous calls and e-prescription with a scanned signature and so on and so forth. We've also put aspirational features against each of these categories, which become mandatory features in the next category. Now, in the advanced solutions, you would not only require to have a TPG compliant solution, but there are various evolving guidelines by ABDM and patient data protection related guidelines. And the IT ministry will have certain other mandatory guidelines that will come up. So solutions have to be agile enough to be compliant with these as and when there is a requirement. Advanced consent management, as I just mentioned, and for patient portal and doctor's portal to be available in the solution, and also to be integratable with the EMR. So what we realized was that, okay, as we are working on this framework, it's okay for the user. It gives the user a guideline as to what he or she can choose for their need. We also realized that it is an excellent roadmap for a technology solution developer. They can work, different levels of solutions. They can, and they understand what is the user's need. Because our assessment, actually, we realized during the assessment that most of the technology solutions that we have assessed, we assessed close to 100 solutions. And we realized that many of the startups that were working, they started with an idea without any domain input from the medical professionals. So it was so they started some features which looked fancy to them and what they thought was required. And eventually when they come to the hospital, you realize that it's not workable. So even for the solution provider, the technology guys who are developing these IT solutions, it's good not to waste their money and their resources and to use these guidelines to develop their solutions in a very gradual manner. So our focus areas, as I mentioned, was on standards compliance, interoperability guidelines, which I'll come to, emerging guidelines and regulations, data security, and focus on reduction of misuse and fraud by making sure that there is a proper identification of the doctor and the patient concerned or anybody else on the call. We also focused on looking at how these solutions had features to ensure that there is patient safety features are interface, drug database interfacing, and certain futuristic features like device interface and platform-based features in future. So some of the patient safety and quality features that we identified in these solutions were about identity management, consent management, e-prescription, data security, continuity of care, audit trail, and digital and health literacy. We also checked for features which are more contextual in the Indian setting. Like our social setting is if patient is ill, means that relatives all across the world, at least 5 people would want to sign into the call. There would be some caretaker would sign into the call. So features whether these were provided. Whether there were multilingual operations possible. And whether there was also the circle of care, like what we said, that there are people staying, the nurses and the caregivers. And people who were functionally illiterate. And I would say functionally illiterate because they didn't understand most of what was happening. So whether they could do a voice typing. So we looked for people who have incorporated features like this. And although some of them did have, But what we didn't find at that time when we were doing was that there was no solution that catered for any person who was differently abled. However, I should tell you that, okay, last 2-3 days ago, I spoke to somebody who's developing a telemedicine solution which can be used by the visually impaired. So it would be, I'm sure when we meet again, I would tell you about that solution. Now, while we were doing this, we understood that most of these people, they said that we don't have an idea of how we can interface with devices, or where are the interfaces, which are the interfaces that can help us capture data. So we took it upon ourselves to figure out who are these people who are manufacturing these devices, and can we evaluate them as well and provide the data to the telemedicine solution developers. And we had the same methodology. We got them screened themselves, and then we had evaluation by 2 different teams at 2 levels. Ask them to do what is their technology readiness level, figure out what is their innovation potential, and what is the initial success rate of the team or the startup company, and further assessment in terms of how they were developing the device to be compatible with telehealth ecosystem, and look at what was the clinical context which they were doing, whether it was a remote data capture, remote diagnostic, or a monitoring equipment, or a teletherapy unit, and we looked at those functions, and eventually asked them to do a practical demo to us. So when you look at all these devices and you see the number of telemedicine applications that are available, you realize that they need to talk to each other to really be effective. And that is what Manisha was alluding to when she said interoperability. So here you see how fragmented our healthcare ecosystem is. You have people working in silos in different areas. And even within this, there are multiple silos. You cannot get continuity of care of a patient, and eventually on the PHR, what is the aim of ABDM, is continuous longitudinal medical record of a patient in the patient's hand on his phone against a UHID. Now, if you have to get there, all of the softwares that we have in this ecosystem need to talk to each other. And that's what is the meaning of interoperability. So if you have in your ecosystem 50 hospitals being addressed to or connected to CMC, you see how powerful your ecosystem becomes. But for that, it requires that your clinical workstation needs to speak to the healthcare, the EMR in A, B, C hospital, or from the devices in those hospitals, you need to be able to capture data automatically, and they need to be seamless. So dynamic, seamless, real-time data capture and communication across all the devices that we use, across all the software that we use, that is what is interoperability. And that needs to be essentially present in your system. Now, we do have multiple software solutions we use. We need to make sure that when we have a contract with all the solutions, when we buy any of the equipments, when we buy any of the devices, that they share APIs, that they are capable of, if they don't share APIs, they're capable of developing a middleware which can talk to each other. All that is necessary. And that, as people who are running establishments, it is our responsibility to make sure that that is part of the contracts that we build in. So because eventually all the healthcare systems are going to be running on a digital backbone. Now, whether you have it as a network or whether you have it as a platform, the decision how to enhance the interoperability possibilities are up to the organization. And before COVID, we used to say that the main deterrent for lack of adoption of digital was that doctors were not accepting, and doctors were not adopting solutions easily. Partly because of the fear of the unknown, because not because I'm a doctor, but even otherwise, I would say that when doctors realize that something is good for them, they are the first to adopt. The only thing is they need to understand how it will help them. or how it makes their life easy. So this is a lack of communication or training that has happened, and therefore, if we learn from medical school, or if the current generation, when they become doctors, I'm sure that challenge will not be there. The problem is people like us. There were no computers when we were training. So that's the problem. And there was also a fear that if you don't touch and feel a patient, you can't make a diagnosis, and the patient doesn't feel happy, and you don't feel happy, and all of that stuff. So COVID, anyway, threw that assumption out of the window completely. And we've realized that you can do the same or sometimes even better care. You don't necessarily have to have the patient and the doctor in the same physical space. But what is the challenge now? And I think the biggest challenge that we have is digital illiteracy of all the stakeholders. And when I say all, medical professionals, the entire gamut of healthcare professionals, and also the patient. Now, if we are looking at PHR becoming a reality in this country, now imagine one of your patients who's coming from, let's say, West Bengal, comes here, and you tell him that, okay, this data is on your PHR. What does it mean to him? Now, he has no idea what a PHR is. Whose responsibility it is to tell him what a PHR is and what is it that he can do? Because he has to give access on that PHR to another person to be able to take his follow-up care. Now, he doesn't know. Can you imagine if he does not know what is the reality of misuse and abuse of the data in a patient's handheld device? Because he doesn't know. He will ask all his neighbors and villagers to tell what the data is, and there is no data privacy anyway. So we have to make sure that if the ABDM plan has to be successful, the responsibility, so it's 50% doctor's job, it is 50% is patient's data. So we have to be very good at entering the data, accurate, seamless, all of that stuff, which we understand. But the other 50% who have to understand what PHR means, we also have the responsibility to educate them. So I think today the biggest challenge that all of us face is how to educate and build capacity for creating this wonderful digital health ecosystem that our country envisages that we will have. So I want to thank all the partners that have worked with us along the way in creating these two maturity models, and thank you very much.
Thank you very much, Dr. Nambiar. Very much on time. Thank you. Let's open for questions. I'm sure you're going to get flooded.
So I have my number and phone here, phone number, and you can ask me questions here. I'm one of those who doesn't mind sharing my number. And I don't think I get crank calls ever, so I'm fine. Yeah. Nobody wants to give me a crank call. I wish somebody would.
Yeah, I think we have Dr. Balu there.
Yes.
Who's going to be asking the question. Yeah.
No, it's not a question. First of all, thank you, ma'am, for having accepted our invitation and also having evaluated our telemedicine solutions and given us a report. We would work on that. And I would like to tell the audience that CMC's internal telemedicine solution, which was developed in-house, was a reflexive one because of the lockdown. We had to do it, and I would thank our CHIPS department for having brought out a wonderful solution. We also have MediBuddy here, who is a vendor-driven solution in this conference, so I would request you to interact with both teams when you have time to understand both sides of it. Second thing that I want to tell you was when I was trying to implement EMR in radiation oncology because it used to stay as paper charts separate from our HIS. When I tried to do that, when we bought a new machine, I had to buy a new license to connect that to the EMR, which we had to pay $20,000. So it was like another add-on. So do we have a vision of having strict regulatory or statutory things by the country to have interoperability for healthcare, especially in technology and devices?
So interoperability is very much part of what the ABDM has proposed, and it is definitely necessary for all the softwares that are going to register with the ABDM. As far as this financial model is concerned, the license model is a very, very costly way for us, and we all know how we lose so much of money and we don't provide for this in CAPEX. over a period of time, what people have realized, and it is for us to emphasize that we will only follow those models, which is pay-per-use models, which is software as a service, or now what people are doing is developing a platform as a service, which is USCMC will develop your platform, which has all your rules, regulations, and all the engines at the back, and all your tariffs and everything you will, including the standards. That's your platform. Now, any vendor that comes can use this platform as a service and plug and play. So that even if you want to throw out a vendor tomorrow, you don't lose any data. You don't lose anything, in fact. So eventually, if this has to succeed, the medical fraternity, the hospital provider, the healthcare provider community has to take the lead. It cannot be led by the technologists and the bureaucrats. Unless we decide how we want to run this solution, it will not succeed. So I think we should also realize that we should not play ball to the multiple difficult financing solutions that are offered to us by the technology providers. We need to make sure that we said, okay, we have this platform, you come and play your solution on us, we use it, if you're not happy, we throw you out, but it is on a pay-per-use basis. What happens is you can charge every patient that delta cost, which is not major for a patient. But for a hospital to run it as a capex, it runs into crores, and we can't really ever justify that cost.
So you mean to say we shouldn't buy from a vendor who is not offering interoperability?
Absolutely. Never. And today it is like clear that they should not. Interoperability and agility to actually look at the future and be futuristic. So we can at least see what the next 5 years or 10 years are going to look like in this digital world. We need to have a talk with them and make sure that it's part of that. They'll give you that 60-page contract which looks like a PhD thesis, but make sure these 2 lines are definitely written.
Thank you.
Yeah, sure.
Ma'am, this telemedicine registry, is it a government or any other kind of communication you have, or
no? So
exactly
right now, if you see, we have it on the NRCS portal. We have it in the Digital Health India portal. It's a private initiative. Digital Health India Association is a Section 8 private, not-for-profit company. We all work for free.
Then you are only looking for the teleconsultation or telemedicine support. Otherwise, now in these days, our palliative care kind of tele-supporting is increased. Something like if a patient is going on warfarin therapy, INR values are more important. They want to update every time. That kind of small applications are there in the industry. All those kind of things you are
we would love to have it in the registry, and we would really, what we would like to have, and we will be discussing with a lot of other like-minded organizations to see how this can become a feature which is usable for everybody. And eventually you can, because this model of evaluation will be available on the registry. Okay. We don't have to evaluate, you can self-evaluate, right? So, and also look at it, because why should somebody else check what you have? Initially it was necessary because, nobody really had. But our job would be to see how we can continuously develop this model and advance it further with the new features that come in.
Thank you, madam. And I think we have time for one more question. Dr. Sumita is waiting there.
From Medical Genetics CMC. Just one practical question. Sometimes the patients on the other end during the teleconsult, they ask, can I video or can I record whatever conversation? So that is all right?
Yeah, it's all right, because one of the requirements in telemedicine practice guidelines is that it is recorded. Not only by the hospital. Eventually, why are we recording patients' data? To be made available to the patient, so it's fine.
Okay, thank you.
Thank you so much.
Yeah,
thanks, Dr.
Thank you so
Uma.
much. Thank you.
Let's give her a good round of applause. I think it's been a great session.